So hello, everyone. My name is Mohammed. I'm one of the RadCast co-founders. Now, today, we're joined by Craig George-McDowall, got there in the end, who is a current ST1 and actually a previous cohort member of the RadCast Academy. He was with us during the 2021 to 2022 cycle, and clearly it paid off considering he's now midway through his ST1, getting ready for his FRCR Part 1. We decided to do this video in response to the growing number of questions about the MSRA. A lot of you are asking pretty much the same question, like how do I prepare? What resources do I use? And rather than giving you kind of outdated experience from when we sat it, which is around a few years ago now, we thought what better than to speak with somebody who not only sat it recently, but actually did very well. And of course, that led us directly to Craig. So without further ado, Craig, do you mind just quickly introducing yourself to the RadCast team?
Sure, yeah. So my name is Craig George-McDowall. I went from F2 to ST1 after a successful application last year. I got my first choice job, and I did use RadCast, and I would say that RadCast was instrumental in me getting my job, and there's other people on my course that say the same thing. I have a bit of a long background. I was previously a dentist, went to do medicine because dentistry was too boring, and then kind of found myself in radiology, which is thoroughly enjoyable.
Don't worry, we don't have a gun to his head to say all that, okay?
No, honestly, it's fine.
On his own free will. So before we move on to Craig selling us his get-rich-quick scheme when it comes to the MSRA, it would be good to know, Craig, from your application cycle, how was the MSRA used?
How is it used? It's used in two ways. The first way is it's used for the shortlist. So everybody that applies will sit the MSRA, and then there will be a cutoff depending on how well everybody does, and that generates the shortlist. So I believe for my year it was 521. If your score was less than 521, you wouldn't go to interview, and your portfolio wouldn't be assessed. And then the second way that it's used, if you've made it through that shortlisting phase and you've gone to interview, is that it contributes towards your final rank. So I believe when I did it, it was a third MSRA score, a third interview score, and a third portfolio score contributing towards your final rank. The year before my year, and I know that the applications change ever so slightly every year, there was a bypass interview number, but they got rid of that in my year, and I don't imagine they're going to include it in the future.
Yeah, what Craig's alluding to was when there was like peak COVID, it was the top 55 MSRA scoring candidates directly go on offer, no interview, no portfolio review. They scrapped it for Craig's year, and I think, fingers crossed, because we thought it was a bit odd, it won't be reintroduced. But of course it is, we will let you guys know. The key thing I want to just pick from Craig's response is how it's used. So he said two really critical things, which I want to summarize. The first is there is a cutoff score. If you don't meet that cutoff score, then unfortunately, you're not even getting through to your portfolio being reviewed. Now, that changes year upon year, reflective of the cohort as a whole who sat it. Now, as more cohorts come in to sit the MSRA, I'm talking about the whole current debacle regarding the core surgical training applications, that cutoff score may then change, but your ranking in terms of how much it's worth is reflective of just the radiology applicants. So it's just important to know, okay, what cohort is used to calculate which, but the fact that it's worth a third, as Craig said, 33%, means it's not something that you should really take lightly, okay? That's why we're doing this video in the first case, just to give you that up-to-date information. Now, in terms of dates, rather than giving you specific dates, which may then change, and then you may be like, okay, well, RadCast said this, the website says that. Let me just give you a blanket type of overview. Number one, the MSRA is typically in the January month of the subsequent year you're applying. So November 2022 applications will typically sit the MSRA in January 2023. Those of you applying in November 2023 will sit the MSRA in January 2024. In terms of when in January you'll sit it, that can vary. But of course, when you come to book, and this is something that Craig will also give us a bit more insight into, it's literally first come, first served. So the quicker you can get onto the website to book, the more likely you can get a date. And unless you have genuine reasons that you can't like pick the later date, sorry, then don't pick the earlier dates, get the latest date you can so you get a bit more time to revise. So with that in mind, Craig, how does the booking process work? Do you get like an email? Do you get like, do you do it on Oriel? What do you have to do?
So you obviously apply for the job through Oriel. You then will get a message, and I think it was the first week of December that I got mine on Oriel. And the way that Oriel's messages work is sometimes a bit janky. So you might get an email before the message, or you might get no notification whatsoever, but other people are telling you that they've had messages, and you go on and you can see it. So you get a message telling you to make an account with Pearson VUE, which is the people that they hire and the test centers they use, and they give you specific details attached to the your application to use to make an account. When you make that account, that's the first step, is just making an account. Then about 2 weeks later, the actual dates are open, and you'll get another message, but again, it's via this janky system where you might not get a notification, or you might get an email first but not be able to see the message, that kind of thing, saying that the slots are open and then you can choose. And I think I would say another benefit of being in RadCast is joining the Telegram group, because that's where you'll see lots of people. You might not know somebody or bump into somebody, or they might not tell you if they're on nights or whatever, that the radiology stuff is out and you can now book your stuff, or you should be making your account. And being on the Telegram group, that's when people will say, yeah, I've booked my slot, it's all out now. I think that's good. At multiple stages, it's nice to have people that are all applying for the same thing, because the invitation dates might be slightly different for different specialties, or the first account creation might be different. So yeah, it's all of my emails were attached to my Oriel account, but the actual booking process happens via the Pearson VUE system. And yeah, you can pick a date. I didn't have any difficulty choosing a date or a location that was suitable for me. There were quite a lot available, but I'm in a capital city, so maybe that's why we have more slots and it's easy for me to get to. Whereas if you're working in the middle of nowhere, you might have to travel quite a long way. So it might be, again, I think it's a good idea to get in early and book a slot that's really convenient for you. You don't want to have to shift your nights, do it after night, shifting long days. That's a lot of added stress.
No, Craig makes a very good point in terms of like, just as soon as you know, just book. That's why we have the Telegram group, which is part of the Clinical Radiology application course, because often we know that you guys aren't in the radiology department, or you may not be with colleagues who are also applying to radiology. And unless you're aware, the slots will go quickly, especially now that we're getting more applicants applying year upon year, especially more specialties now having to use the MSRA. In the Telegram group, either we will inform you of something that we're aware of, like the dates from the RCR for the application being confirmed. We'll just send you the link. Or as Craig said, somebody will say, oh, guys, I've booked it for radiology. It's also open. And you're like, okay, quickly, let me just drop what I'm doing on the ward round and quickly go book a slot. So you've booked the exam. Now, Craig, the exam date is there. You're ready to go. You've had your Red Bull. You've had 2 hours of sleep. You're ready. You're stressed. You're ready to go smash it. What happens on the actual day of the exam? So you've booked the Pearson VUE Center. Like, what happens next?
So on the day you go, you turn up, you get there early so that you know you're not going to have the stress. You park, you wait outside for a bit because you're ridiculously early, and then you go in. And it's a place where people do their driving. You've probably been there already, doing a driving test. I think people do their visa applications. Other specialties are using it, like the public health exam is there. I think maybe some government things. Lots of stuff happens there. So you're not just with doctors doing the MSRA. And mine was in like a high rise. There's like a lobby and a kind of closed off quiet room where there are lots of computer banks, where you probably remember sitting your driving, the visual thing you had to do. And you have to hand in your ID. They get you to sign something, and they'll tell you to put all of your stuff in a locker. You can't go to the bathroom during the exam. You can't have a drink. And my center was exceptionally strict in what you could wear. So I had a hoodie on and they made me take it off, and it was January, so it's quite cold. They make you pull out all of your pockets so that they can see there's nothing inside you. Spin fully around. I had to take my glasses off and put them on the table for them to be inspected. I had to take my COVID mask off and show them inside of it. Didn't have any papers. It's crazy strict. Then once you've gone through that little like strip search, you go into the quiet zone and you sit down at a computer. You click through some prompts, and there'll just be, these are the kinds of questions. This is how you select your answers. This is how you organize your answers. And it'll tell you when you're ready. And then when you're ready, you go through it. I think you sit the clinical one first. Is that right?
Yeah.
I think that's correct. And then you will get an opportunity then in between the two to go out and get a drink if you want, or go to the toilet. But it will say like, are you sure you want to continue? If you don't want to do that, so it'll say, you have to say like, yes, I am sure, and it'll say, do you want to break? And you have to click no, that you don't want to break, and then you can go on to the next exam. And then once you've done that exam, you walk out. You do get a piece of paper, but it's useless. It just says that you were there on that day and you sat the exam. You don't get any results or anything instantly. And then that's it. It's very strict.
Sounds more strict than like an airport search. Where I'll be surprised if they don't start doing that soon. Where you go in and be like this, and it's like just do an X-ray of you quickly. But I didn't know they made you like take off your glasses. Like what?
I had to take my glasses off, put them on. I guess because Google Glass or something. I don't know. And they were literally, every pocket had to be examined. It was very, very strict.
Jeez, fine. So there you go, guys. You've been warned. Don't take hoodies. If you can wear contact lenses, go wear contact lenses, but just get ready to be thoroughly searched. So one thing we get time and time again, especially from the more official bodies of the MSRA, is that they often say, listen, don't stress. This exam is aimed at a foundation year 2 level, so you should all be thoroughly prepared for this. And we just want to ask, like, honestly, on a level, Craig, is that true? Or do you think it's more complex or less complex?
That's an interesting question. So I don't think it's particularly complex, in that I don't think it's at the level of postgrad exams like MRCP. It's not at that level. But equally, I wouldn't say that stuff that I had to learn and was asked about during the MSRA was actually relevant to any of my F2 jobs in particular. I did have to specifically learn stuff for this job, and if I hadn't have done any revision, I couldn't have just used my year and a bit of experience as an F1, F2 to get you through the exam. I'd say the level isn't far off of medical school finals, and my medical school had progress tests where we sat very, very similar broad exams that covered all specialties. And I would say that the stuff is most relevant to GP. It's not related to any of the specialties other than GP that sit the exam in particular. And I'd say the SJT portion is pretty much exactly the same as the FY1 SJT that you sit for your F1 placement. So I wouldn't say it's at a high postgrad level, but I wouldn't say that you're just going to know this stuff based on having been an F2.
No, I really like the way you've described it. Definitely not as like intense as like fellowship exams like FRCR,
No.
and you said MRCP. And I like the way you said it's like medical school finals. And the thing that I agree totally when what Craig just said is that, remember, in F1 and F2, you've kind of not been using medical school final knowledge at all. You've been more of like an administrative type of person. I could say more descriptive words, but we're trying to be PG friendly. But it's more that you're not really applying your clinical knowledge. You're more doing administrative tasks, referrals, TTOs, prescriptions. So all that bank of knowledge that you had before your medical school finals is kind of dipping and dipping. And unless you pick it up again, so for example, as Craig said, through revision, you're not going to know the pediatric milestones having done a vascular job. I don't think that's something you do on the ward round at 8 a.m. And unless you get certain rotations strategically during the year, so for example, a general practice rotation or maybe an A&E rotation, a lot of the clinical stuff you will not have touched. So I remember in my MSRA, I did get a question on the immunization schedules. Now, my jobs at that point had been endocrine, vascular, psychiatry, and I was now on an A&E job. So why would I be doing like immunization schedules unless I was like totally going off on one? So I agree with Craig. It's not as difficult as fellowship exams or postgrad exams. And if you can get to the level of your knowledge of medical school finals, you'll absolutely smash it, because that's what like the clinical side of things requires from you. So you mentioned there was two different sections, Craig. Can you just elaborate on what those are?
Yeah, so there's an ethical scenarios section, which is like the SJT. So I think there's 50 questions. They're split into two types. So there are the ranking questions where you'll get a scenario and then 5 responses or things to consider, and you rank them from most appropriate to least appropriate. And then the other type of questions in the ethical one is choice selection. So you'll get another scenario and you'll get maybe 8 responses, and you usually choose 3 that are the most appropriate or the most important things to consider. So that's the ethical section. And then the second section is the clinical section, which has 2 types of questions again. One is just multiple choice, best out of 5. What is the most appropriate answer? What's the single best answer? And the stems are quite short for that. And then the second one is extending matching. So for that, you might have 3 questions, but they all pull from the same, usually a larger pool of answers. And it'll usually be 8 different drugs or 8 different diagnoses or 8 different investigations. And you pick for each separate scenario what the most appropriate is. So you might have different scenarios and you're choosing a different antihypertensive agent for different patients that are presented in the different stems. And those are the only 2 types of questions in that. I think there's 97 questions in that section, but it is shorter overall. I think it's 75 minutes. I didn't need any of the time, like I didn't get to the close to the wire in either of the exams. I think by the time you get there, you're going quite fast. And some of the questions that you have won't actually be used for your answer because they're actually testing and trialing some of the questions, and but you can't tell which ones they are. So they're just hidden amongst your questions. There'll be some that don't actually contribute. So even if you find 5 that you can't do, some people, those 5 are going to be not contributing to their final answer, and some people they might be, but you just don't know. So you have to do your best.
Yeah. So like Craig's alluding to like the pilot questions, which you won't know. It's annoying because you're under an exam scenario, but it's just unfortunate. You won't know. Just do them as you can. Obviously, remember there's no negative marking. So please, whatever you do, do not just leave a question blank saying you don't know. Just have a go. It's luck of the draw. Maybe you'll get it right, maybe you won't, but at least you've given some chance of getting it right. And yeah, there's clinical scenarios, and then there's these ethical professional dilemmas type of thing. So let's focus on one at a time, Craig. So for the clinical side of things, what was number 1, your revision strategy? And number 2, like if you could go back, would you change anything to make it more efficient? And honestly, like if there were any specific resources you use, please just feel free to name them. We don't mind like giving outs to like specific resources or companies, especially if you use them and you got like 600. So it clearly worked. So yeah, what did you use for the clinical and what did you use for the ethical side of questions?
Okay, so we'll start with clinical. The clinical one is the one I think you can control, because that's what people mostly feel. Because there are answers that are going to be right and answers that are going to be wrong, and it's a lot more objective than subjective. I didn't really have to do any revision in my final year of medical school. Half of that was because COVID cancelled a lot of my final year of medical school. And then, as you say, I've not sat any other postgrad exams. I basically haven't touched a textbook since medical school year 4. So it had been 2.5 years, and I was very concerned that I was going to be very rusty. So I needed to do a lot of work. And then secondly, my rotation at Christmas, where during the exam, was A&E, which I thought was going to have a hideous rota. And I was going to be having lots of long nights, lots of twilights, not a lot of rest in between. So I started revising early because my block before that was a supernumerary 9 to 5 job, and I had the evenings to spare. And again, knowing how much I wanted radiology and knowing how competitive it's becoming every single year, meant that it was really important that I try and do a lot of work. So going to start saying is that I did a lot of work for this exam. Obviously, it all worked out for me, but I think there probably are people out there who didn't do quite as much and scored well, better, or equally well enough to get to get good results. So I'm not saying you have to do everything that I did, but I think if you put in a good amount of work for this, you'll feel better at the end of the day. So I started loosely in about September, and then I increased that in the last 2 months of my easier block before A&E. I didn't use any textbooks at all. I literally didn't pick up a textbook. I don't really use them. I started off with PathMed, the question bank, because that's what I'd used as a medical student. And I went through that doing my goal was like 100 questions a day when I was choosing to do questions. It wasn't every day. And I would do them by specialty to begin with, because I didn't really have any knowledge, if I'm honest. It all faded away, and I knew how to organize an echo in my hospital, but I didn't know which antihypertensive to pick first, essentially. So yeah, I started by specialty to kind of build a bit of a base knowledge, and most of the specialties on PathMed have got about 200 questions. I finished PathMed, it's got about 2,500 questions, but that if you're doing 100 a day, that only takes 25 days, which is 1 month. Then I moved on to MCQ Bank and did the same again. So by specialty, MCQ Bank has questions that have been on old exams, and it says so in the bottom. So I marked these as my favorites because I thought by the end of doing all the questions, I could then sit a pretend MSRA and see how I was doing. Once I'd done them all those questions and made notes on things, I then started going through them 100 questions a day in just random, mixed bag of anything. You can look on PathMed and MCQ Bank actually, and look at, if there's a specialty that you're not very good at, it does tell you that. I think it's really important with PathMed. The benefit of PathMed is to look in the comments and see because people will make comments about the question, and if you've got one wrong, people might be like, "This question's ridiculous or stupid or wrong." And equally, there might be real golden nuggets of information in the bottom in the comments, like here's an acronym for this. Here's a diagram of a bear that tells you all the different chemotherapy drugs. It's called Toxicity Bear, and we love it because it'll be asking you all the different side effects of chemotherapy, and if you draw a toxicity bear, you'll know which one it is and what it's affecting. So yeah, there's nuggets in the comments there on PathMed, so that's really useful. I did actually manage to go through both of them twice. I don't think many people do that. And then I probably started a bit too soon for myself, but I couldn't have known that in hindsight. So I started to get a bit bored around Christmas time, and I was getting sick of PathMed and MCQ Bank, which is not surprising considering I'd done them both twice. So then I bought PathTest. PathTest has good questions. They are very short, which is a lot like the exam because the exam stems are exceptionally short compared to PathMed. You'll get these huge chunks of text, and it's just not realistic, but it's still teaching you the right thing. And the information is there in the kind of why is this the right answer? So it's still a good resource. PathTest was fine. Some people would prefer it. You can use that on your phone, so it has an app, whereas the other two don't. So if you've got a really busy job, but you might get 20 minutes at lunch, you could do some questions on your phone. I didn't do that, but you could. And that was pretty much how I revised for the clinical one. And in the last week, I had kind of a planned week of mostly time off, and I tried to do about, maybe I went a bit crazy towards the end, like doing like 300, 500 questions a day, just really fast. But you do get really quick. You might think it's ridiculous to do 100 questions a day, but you could probably do that in about half an hour by the time you've done them, because you're just training yourself to see the clue that's in the question and then pick the one answer that's right. So a lot of stuff is like pathognomic. It'll be baby's being sick, doctor feels a mass, pyloric stenosis, it's just like the two links. That's how it works. So yeah, that's how I prepared. I didn't use textbooks. I did start with PathMed. I would recommend starting with specialty first, and then going through them just as little exams afterwards, and then maybe working on areas that you're weak if that's something that's particularly the case. I did also make an Anki deck of some of the stuff that you just have to memorize, that you can't learn or there's no reason for it. Is there a reason why HPV 16 is the one that causes cancer versus warts? No, it's just a number that is connected. So I did kind of make a small Anki deck on a free app on my phone, and we do those occasionally. But yeah, that's how I prepared for the clinical section.
No, that's really interesting. Now, some of you may be very like risk averse in doing questions first, and I can understand why. People don't like that failure, like opening up a question bank and starting getting 100 wrong. Now, I the same strategy as Craig, and often this is something we recommend at RadCast. The reason why is, okay, if we tell you what textbook to get, you're number one going to have to read from A to Z if you want to have that comfort blanket around you. But really, the textbooks we're going to recommend are going to be like Oxford Handbook of Medicine and Clinical Specialties, or your Kumar and Clark, or your Davidsons, basically any textbook that covers medicine and specialties from A to Z. So if you want to spend a good chunk of your time reading those books from back to back, go ahead. But remember, this isn't medical school days where you have the luxury of time. You are expected to work as a junior doctor. So often textbooks become an unnecessary waste of time. Whereas with questions, and I really like the strategy Craig employed and deployed, it's literally you go in there, you get stuck in, you realize, okay, I suck at hematological malignancies. I need to go read up on it. Or as Craig correctly did, which I thoroughly recommend, is learn the buzzwords, because that's what you want. Now, some of you may be like, oh my God, you're doing 100 questions a day. Trust me, if you're genuinely like ready to get into radiology training and you want to get that training number, and as Craig correctly hit the nail on the head, it's getting ridiculously competitive year upon year, probably going to go up this year again. You have to get to that level. Like, honestly, it's where the third of your application, 33%. And if you're not putting in the time, it's that old adage, if you prepare to fail, you'll fail. If you fail to prepare, you'll get ready to fail, prepare to fail. So honestly, just don't be like put off by Craig's strategy. Somebody like, oh my God, that's so much. Like, if you're seriously dedicated, then that's like, you should be putting in that much. I've not heard of the toxicity bit. I need to go look that up, see what that's all about. But that's such a good strategy. Like, that's the first I've heard of it, where you got all the past questions on MCQ Bank and you made it into like a mock exam. That's a pretty good idea. I really like that. And yeah, past medicine, those little snippets from other candidates. Often they're just moaning, oh, what a crap question. It's all rubbish. But they are, like, as Craig said, pearls of wisdom in there. So that's the clinical side of things. Craig, what about the more like professional dilemmas, ethics questions?
So people mostly complain that this is something that you can't prepare for, and I don't fully agree with that completely. I think it is harder to prepare for, but I didn't do terribly bad on my SJT when I was an F1. I didn't need it in the end because I'd had an academic post, so I had an interview instead. But I've sat these kind of things before, and I was never like some horrific person that thinks the first choice is to punch the nurse and then to run out and set everything on fire. But I think so. How I prepared, I tried to read good medical practice because that's what people usually suggest. But it is just basically a list of bullet points that are like, be nice, be trustworthy, be honest. So then I did try. I don't know how much I really did, but you could try that, and people do suggest that, and it's not a massive amount of text or anything. Then I did the 2 SJT papers that are put out by someone somewhere. There are these 2 SJT papers that are the mock exams for the F1's SJT. And the reason you do those is because they're actually from these kind of people that set these things. The problem with doing question banks is that people submit questions for PassMed are not the same people that are writing the exam. So their reasons for why this choice is higher than another choice in terms of what the most appropriate thing to do might not actually be reflected in the exam. So I would stay away from PassMed's SJT section completely. You do probably get it for free, but I wouldn't do it. I did do the MCQ Bank one because, again, that one has questions that are from the actual exam. And I did have one question that I'd seen on the MCQ Bank question bank for the ethical dilemma that came up in my exam. Wow. And I remembered the answer. So it was good. And then, other people might have more than one that come up. MCQ Bank, yeah, that's what I did for that. I didn't do anywhere near as much for the SJT. I consciously left it until probably 2 weeks before the exam, or maybe it was even the week before, is when I started doing those things because I didn't feel like it needed as much dedication.
Mhm.
There are some patterns that you will be able to pick up by doing some revision. So I don't think it's a good idea to do nothing for the
Mhm.
SJT because people just say it's a random number generator. The patterns are things like who to escalate to, when it's okay to break confidentiality, and usually things are like if patient safety's at the top and then maybe your safety might be a little bit below. Um, a lot of questions are talking about like going back into work, or if you've not done something or doing extra work. And if you've not done a lot of these exams, you might think, well, I'm trying to be the best, hardest working doctor that they want me to be, so I'm going to drive back in after my shift and correct some mistake. But actually you need to think patient safety is up there, and if you can't get a message to someone, you might need to drive in. But before that would be kind of like making a phone call and asking your team members to help you. So I think there are some kind of little ladders that you can learn. I don't remember like specifically writing anything down or making an actual note during this preparation. It was just something to absorb from the 2 FY1 papers and the MCQ bank thing. So I'd say it's a lot less heavy. I didn't do as well in my SJT as I did in the clinical scenario. The clinical bit gave me the majority of my mark, but I still did like very well enough.
Mhm.
Um,
No, I
yeah,
think the thing that I like from that strategy, Craig, is often you see with the clinical, and this is what I think Craig was really emphasizing, it's very fixed. It's yes or no. You know the answer or you don't. With the dilemmas, it kind of becomes this dubious like ether where it becomes my word against yours. And this is the problem with question banks, is it if it becomes Mohammed's question bank and Craig's question bank, we could have the same question, but I could approach it totally different to Craig. And as Craig really like correctly said, these people who write the question banks aren't the people who write the exam. And the problem is if you like use the same strategy for the clinical, for the ethical, you're going to get conflicting types of approaches. And
absolutely.
you'll end up being like, okay, so past medicine said do this, but MCQ bank says that, past test says this, e-medica says that. What the hell do I do? And you just end up, and if you get that question, you'll just be like, wait, I don't know what to do. And you end up just like freezing and going like totally blank. But I do agree with what Craig said. There are certain things that have like fixed protocols. So if one is escalation, you don't necessarily escalate directly to the consultant. You go through your like senior registrar, consultant, medical director, blah, blah, blah. Those things you have to kind of learn. But those things don't take time, like necessarily like months of prep. You can just learn that maybe within an hour, just a hierarchy. And those past papers are golden. Like those are the things that are written by the examiners who set the questions, and their explanations are also very good because they kind of tell you, okay, we're kind of using this principle of do no harm, and that's why A is ranked 1, B is whatever. But often you kind of get like paralysis by over analysis if you do multiple question banks for the ethical. Like I remember doing that strategy and it did not work well for me because I was like, okay, I have these notes now on professional dilemmas, but I'm not sure which notes are correct. And then I had to apply my own logic. But you gotta remember, nobody cares about Muhammad Khan's logic in the exam. They care about what is the correct answer. So I think that approach does make sense. Like, don't go so hardcore on the ethical side of things. Obviously, don't neglect it. And there are some good general medical council like scenarios that kind of put the ethical principles into place. One thing I want to say though is this is for our international medical graduates who may be directly applying from their home country, is you may need to spend a bit more time
Mm,
on the ethical dilemma side of things. The reason why is because those of us who have trained in the UK or are currently working in the UK, we are exposed to the environment around us, and often we learn by diffusion. So we may have had either lectures in medical school where we've covered a bit of this in our OSCE examinations, even our written examinations, and especially when we're working as junior doctors, we have to deal with ethical scenarios all the time. Of course, what we do may not reflect what we should have done, but there is that diffusion process. If you've not had much exposure or any exposure to the UK healthcare systems, then perhaps you need to spend a bit more time understanding the ethical principles which kind of dictate our work pattern, especially making sure you're utilizing the principles and frameworks referenced by the General Medical Council. So if you are in that position, then perhaps, yes, perhaps
Spend a bit
invest.
more time.
Yeah, spend a bit more time. So Craig, you started around September time. Would
Yeah.
you say on reflection that was too early, too late, the sweet spot? What would you say for yourself?
So if only with the power of hindsight, it was too early. Because like I said, I got bored of the question banks around. I was ready to sit the exam before Christmas, for me, and the amount that I'd managed to do by then. So then I had this challenge of trying to maintain it just over Christmas period and into January, and I wasn't really learning anything at that point. I was just making sure I wasn't forgetting anything I'd learned. But I wouldn't, going back in time, it all worked out. I wouldn't change it, and I didn't know how my A&E job was going to affect my ability to revise. Equally, I might have thought, oh, I'm going to learn so much stuff from being exposed to the unselected take in A&E. I'm going to gain loads of information, but that didn't happen either. It was just more admin. So yeah, it's A&E medicine, which is different. And none of the stuff I learned in A&E would have helped me in the MSRA at all. So I wouldn't go back and change it. But in hindsight, I'm able to say that I would have been fine if I had started a month later and everything had worked out as it did. And I just had to maintain things over Christmas. And I wouldn't panic, and because it's already October, and if you're listening to this now going, oh my God, I've already lost a month and I haven't started yet, I wouldn't panic about that. I think it's very dependent upon who you are, what jobs you've got, what your rotations are like, what your family life is like. I know people that started in August on my current training scheme, and because I've been asking around, knowing that I was going to come and do this talk, and there were some people that said, yeah, I started in August and I was an F3 because the year before I'd sat it and I hadn't gotten in, so I was like, I'm absolutely going to smash it this year. Everyone has a different take, and I don't think there is a magic day that you can say start in October it'll be fine. I think it is very personal, but I would say, as we've kind of hammered home, you can put stuff into the clinical side, and the more you put in, the better you should feel about whatever result you get, because you'll be able to say that you've given it your hardest shot if you have done.
No, I think that the key takeaway is how Craig was emphasizing for me. And the reason I say that's critical is because go back and look at Craig's thought process as to when he should have started. It wasn't like, oh, today it's sunny, let me start. It was more like, okay, I'm currently on a 9 to 5. I can really utilize the time, but I know in December I'm rotating to a rotation well known for a horrendous rota. You may be in the opposite circumstance where you're like, I'm currently on a horrendous rota and I now will be transitioning to, for example, GP or another supernumerary job. So you can ramp it up. So you could start now a bit casual, just getting through the questions, but then you ramp it up in December, knowing you've got a bit more free time. Others, because they are just, in essence, want to make sure that they leave the exam hall thinking I gave it my all, as Craig correctly said. They start in August, they start in July, they start whenever they like, now I need to get in. So as long as you have a plan and a method to your madness in terms of when you want to start, then it's entirely up to you. When I started, I was on an F3 year, so I had the luxury of time on my side. So I kind of just fixed on my calendar my revision days, and then I picked up locums in between. If you're in a current F2 job or another training job or a like a core training job like CST or IMT, you have a fixed rota. You already have a rota, so you need to kind of work around that. People on like the academic blocks, yes, it's again 9 to 5. You can utilize the time there. So we've done the MSRA, Craig. When do you typically get the results? Like, is it, you said it's not directly after, is it like at the end of like January, just before your interviews, that kind of thing? And how is it
Yeah.
presented to you?
Okay. So I can't honestly remember if I think it's about a month later. And I'm sure for us, our result came at the same time as our acknowledgement that we were going to be interviewed. It wasn't like, here's a number, and then a month later we found out that that was the okay number. Because if you got 525, you might see, there was no time where you could see that number and then think, oh, I might make it this year, I might not. It all came at the same time. It was an update on Oriel, and again, the Telegram group was going crazy on that day, and you're checking your phone every kind of 10 minutes and it doesn't come at the same time for everybody else either. So like, some people were getting stuff and you're just like shaking, going like, is it going to be me or not? So you go on Oriel and you look at the shortlist. There's kind of like, with every job application, you get a flow chart, which is like these little circles, and it'll be like shortlist, invited to shortlist, then shortlist, or something like that. And it's a bubble, and it's green if you've made it through, and it probably goes to yellow or red. I imagine yellow maybe while it was pending, and then red if you don't get through. And you click that bubble, and it'll tell you the result. And then it will tell you your split in your two sections. Not that it really matters at that point, but it might help if you're unsuccessful and you need to reapply and you think, have I really like not understood something about the SGT, or have I not? Yeah. Where can you target your revision in the future? And then at the same time, I believe that was when I found out, because obviously the bubble was green with my score inside it, and that meant that I would be having an interview, and then maybe a little while later the interview booking process begins in a very similar fashion, a message on Oriel and another kind of external link to book it.
Fine.
That is how I got my result.
So once again on Oriel, and just look at those bubbles. Yeah, but once again, the Telegram, I remember that day, because we are,
of course, you will.
We're apprehensive for you guys, because we're on the Telegram going, okay, somebody's got the result, they're happy. Okay, why is everyone else quiet? Then we're like, oh crap, what's going on? But I remember that day became everyone's like, oh, the days are out. Not only results are out, but like, oh, interview dates are being fixed. Everyone book. But it's interesting to know that not everybody gets at the same time. I thought that was the case, but clearly just be a bit patient and eventually it will update for you. So final question for you, Craig. Often people end these type of like talks with this, oh, if you have one top tip for the MSRA, what would you give? Forget the one top tip. If you have like tips in general, what would you tell the listeners?
So I don't know how well perpetrated the rumor that you don't need to revise is, and that F2 is going to be enough. My tip is to work hard and think, and you are going to need to revise for this. It's a very specific exam. It's not something that I think it's very unlikely that any F1, 2, or something else would come with the knowledge just naturally. So I would say, if you want to get into radiology, it is extremely worthwhile putting in a lot of effort to get through, because not only does it get you through the shortlist, but it also then contributes a fairly huge portion of your final rank as well. And that'll mean it's more likely that you actually get a job, and more likely you get a job where you want to go. The year before, when I was in F1, I worked with a anaesthetist, a wannabe anaesthetist, who was a locum ITU doctor who had to do the MSRA to get an interview for anesthetics. And I know that this clinician was just incredible. They could do they were unbelievably brilliant. And I was like, you'll walk this interview, but they didn't even get an interview because of the MSRA, and they didn't give it the time and all the respect really that it deserves. And I think if you want to get into radiology, you might end up regretting it if you just go, oh, I'm just going to see how this goes, or I'm going to do a week's worth of revision. It did, take up a significant portion of my time for that period, but I have no regrets about putting the amount of work in that I did, because it's such a huge thing. And there's only like one chance in radiology, and then you have to wait a whole nother year. And there are people on my scheme that happened to now. And yeah, they had to do an extra year of locuming, or they had another gap of being able to decide what they're going to do. And that sucks for them. So I think if you want to get in, treat it with respect and do some work. And I'm not saying you have to do exactly what I did or exactly the amount of work that I did, because maybe you don't. But I think definitely consider this a warning that it's not something that you can just walk into and pass, even if you're clinically brilliant, as I'm trying to illustrate with my anesthetic example. This person is a brilliant doctor, and she would be a brilliant person doing the job that it's supposedly gatekeeping from her, but she didn't even get a chance. You know, what's the point in having a portfolio of a 10 out of 10 if you get 520 on the MSRA and don't get an interview to talk about that portfolio?
No,
That is my number
yeah.
one tip.
No, I think you've really hammered the point. And I love the way you said respect the exam. And that's the thing. We see time and time again, and trust me, Craig was not one of these candidates. Even from day one when he joined our community, we knew straight away he was like going hardcore. And we were like, this is a good example of this. And we year upon year see candidates who kind of go, yeah, it's an exam for GPs, because it was historically designed and implemented to help with the GP recruitment process. So they say in a negative connotation, oh, it's just for GPs, i.e. it's a walk in the park, because this person is a budding neurosurgeon, a budding ophthalmologist, a budding radiologist. And then they do horrendous, because the exam, you didn't treat it with respect, and the exam is not going to respect you back. And ultimately, they don't even get through to shortlisting, i.e. even get to present their portfolio. And this is the thing that Craig correctly said. You may have a 10 out of 10 portfolio. You may have done some original research that's changed the world of radiology, but you won't even get to the interviewers, because by that time, you've been kicked out of the entire application process. Similarly, if you're going down the academic clinical fellowship route and you don't already have an existing training number in radiology, you also will sit the MSRA. And just because you have an offer for the ACF doesn't mean you can just turn up and get everything wrong. You still have to meet the threshold for getting shortlisted for interview. It's unanimous, okay? So take away from this video or this short webinar we've done with Craig is please respect the exam, give it the time it deserves, and then touch wood, you'll get into the training number you've been working your butt off. It's just a few months of revision, but then once you're in, as Craig will testify as a current ST1, you're in. And now all you have to do is get through the FRCR exams, and there you go. There's your consultant job. Which is
you're going to be revising again anyway. So get used to it, because you're going to be revising again a year. You know, it's a year later, and I'm now thinking, right, I now need to over prepare for FRCR Part 1, and it's just the way of life in medicine, really, isn't it? I know why people don't respect the exam, and it's because it's frustrating to say, why do I have to memorize the immunization schedule to be a radiologist? It's not relevant. It is frustrating, but if you don't respect it, you probably won't score well, and then you lose that chance for another year, and that just is rubbish. At least if you put the work in, and even if you're unsuccessful, you don't need to feel bad about yourself, because you've been unlucky rather than kind of, I don't know what the word is, but yeah.
But yeah, thank you.
You've been unlucky rather than complacent.
Yeah, that's the word, complacent. And that's the thing that gets people, complacency. But thank you again, Craig. This has been really insightful. All the best with your FRCR Part 1. It's a shame they brought the exam forward, meaning your entire ski holiday has been kind of put in jeopardy. But hopefully after you pass it, you can go enjoy the skis of... Where were you going skiing? Alps?
Well, no. I was going to land in France, but maybe I'll change it now. I've had a refund. We'll see. We'll just see. It'll be fine. I guess I was going to ask you actually, but it's probably, I've got a question for after the webinar about your preparation for Part 1.
Yeah, we'll cover that separately. But thank you again, Craig. For
no
those
worries. Best of luck to everyone.
Yeah, best of luck to those of you listening in who want a bit more guidance. Please just email in at hello@radcast.co.uk, and we'll get back to you and give you that personalized support. If you want to join the Telegram group, please join our clinical radiology application course. That's where we give candidates who are part of that course like first information about like updates, like for example, MSRA booking is now available, all that kind of stuff. But yeah, thank you again, Craig, and see you guys later.